Welcome to EM Rapid. Now we are going to discuss about life-threatening chest injuries. So the consequences which will happen because of thoracic trauma is hypoxia and hypercarbia. And hypoxia can lead to lactic acidosis and hypercarbia will lead to respiratory acidosis. So these are the complications which will happen, and other complications include hypotension, which might be secondary to hypovolemia or obstructive shock. And in thoracic trauma, operative intervention might be required in only less than 10% of the patients, and 15 to 30% of patients presenting with penetrating chest injuries might require surgical intervention. So, other all life-threatening thoracic trauma can be treated with needle or finger or tooth thoracostomy. So, what all are the clinical features? So, clinical features, if a patient is having chest trauma, they might complain of chest wall pain, that is referred to abdomen, pain radiating to the neck, shoulder, back or upper limbs. Patient might also be tachypneic or dyspneic. And on examination, we should look for any contusions or abrasions over the chest, check for seatbelt sign, check for any flail chest, any open wounds, check for distended veins. Distended veins might be seen in pericardial tamponade, tension pneumothorax, cardiac failure, etc. And check for the air entry, which air entry might be reduced in one side if the patient is having tension pneumothorax or hemothorax. Also look for subcutaneous emphysema, which might be secondary to laceration to the lung or torn bronchus. Also look at the abdomen. In the abdomen, if the patient is having scaphoid abdomen, it might be because of diaphragmatic injury and the bowel might have penetrated into the thorax. Check for the bowel sounds also. If we are hearing bowel sounds in the thorax, that means there might be a diaphragmatic injury. So, what is the criteria to take a chest X-ray in a patient presenting with thoracic trauma? So, if a patient is having age more than 60 years, and if there is a if the trauma is a serious type of trauma, that means a fall from more than 20 feet height, if there is a history of motor vehicle crash at a speed more than 64 km per hour, patient is complaining of chest pain, and if the patient is intoxicated, or if the patient is having any altered mental status, or if the patient is having any other distracting painful injuries, or patient is having tenderness on palpation of the chest, these all are the criteria for a chest imaging in patient. And if anything in this criteria is becoming positive, we cannot leave the patient without doing a chest radiography. So, we are going to discuss about the life-threatening injuries. So, life-threatening injuries should be identified in the primary survey of the patient. So, in the airway, the life-threatening injuries can be an airway obstruction or a tracheobronchial injury. In the breathing, it can be a tension pneumothorax or an open pneumothorax or a massive hemothorax. That will hamper the patient's breathing. And in circulation, the patient might be in hypotension secondary to massive hemothorax, or a patient might be in obstructive shock because of cardiac tamponade, or patient might present with a traumatic circulatory arrest. And in secondary survey, these are not the life-threatening injuries, but in secondary survey, we should also look for the other chest injuries like simple pneumothorax, hemothorax, flail chest, pulmonary contusion, any blunt cardiac injuries, traumatic aortic disruption, traumatic diaphragmatic injuries, or any blunt esophageal rupture. So, we will mostly discuss and focus on the life-threatening injuries. So, in the airway, first is airway obstruction. So, airway of a patient might be obstructed because of any aspiration of blood or vomitus. Patient might be having some laryngeal injury, or the airway might be compressed by any posterior dislocation of the clavicular head, or any other penetrating trauma to the neck or chest. So, when we look at the patient might be in air hunger. There can be intercostal and subcostal retractions. There might be any foreign body that is obstructing the airway. Patient might have any change in voice quality or stridor. And if the patient is asphyxiated, there can be features of subcongenital hemorrhage, petechiae, vascular engorgement, facial edema, cyanosis of the head, neck and upper extremities. And then feel for any crepitus over the anterior part of the neck because of any air leak. So, by doing some temporary measures like clearing of the blood and vomitus from the upper airway, that might be some temporary measures, but definitive measure is to intubate the patient and find a definitive airway to the patient. And if we can palpate some sternoclavicular joint defects and all, we can reduce the posterior dislocation or the clavicular fracture by grasping the clavicle with a penetrating towel clamp, and we can relieve the obstruction. Then other chest injury, life-threatening chest injury in the airway is the tracheobronchial tree injury. So, it usually happens when the tracheobronchial tree is injured within 1 inch of the above the carina. And it is severe and patient might die at the accident scene itself. And the mechanism is rapid deceleration following a blunt trauma or any blast injury or any penetrating injury to the neck. So patient might present with hemoptysis or any features of subcutaneous emphysema secondary to air leak. Patient might be in tension pneumothorax, and patient in the late stages patient might be cyanosed. And the fatality depends on the inadequacy of the airway, development of tension pneumothorax and pneumopericardium. So, in this patients, we need this patient's airway to be patent, but intubation might worsen the injury, and sometimes the endotracheal tube might penetrate through the injury. So, intubation is a tough task here, and intubation, other factors which will make the intubation difficult is a paratracheal hematoma, associated oropharyngeal injuries, and and the tracheobronchial injury itself. So, in such cases, we will opt for a fiber-optic assisted endotracheal tube intubation and tube placement. And or we can also do a selective intubation for an unaffected bronchus. If a particular bronchus is injured, we can selectively intubate the unaffected bronchus. And incomplete expansion of the lung and continuous air leak after placement of the chest tube. So, if suppose we didn't identify that this patient is having any tracheobronchial injury, and if we identify it as a simple pneumothorax case, and even after placing chest tube, we still find that this patient is having chest is not expanding, it might be because of the continuous air leak. So, in such patients, they might require 1 or more ICDs. And to confirm tracheobronchial injury, we want a bronchoscopy, and the definitive treatment for this one is a surgical consultation and surgical repair of the injured trachea or bronchus. So, in such patients, we should, when we are looking this patient, we should check whether the patient is having adequate respiration or not, palpate for the areas of any tenderness or crepitations around the neck, and auscultate for the air entry. So, tracheobronchial injuries can be an easily missed injury. So, specifically look into this, and we should then only we should diagnose this. And if at all we see this patient in distress, and if we without thinking this in mind, and if we are intubating, we might penetrate through the trachea. And other signs are increased respiratory rate and change in respiratory pattern. There can be progressive shallow respiration, and cyanosis is a late sign. Next life-threatening injury in breathing is a tension pneumothorax. So, tension pneumothorax is a pneumothorax with hypotension. So, what is happening is there is a one-way valve through which air is leaked into the pleural space. So, air is forced into the pleural space like that, and there is no way for the air to escape. So, the side in which there is pleural pneumothorax, that side the lungs will get collapsed. And ultimately, the mediastinum might get displaced to the opposite side, compressing the opposite lung and decreasing the venous return because of the increased intrathoracic pressure. So, patient might be in obstructive shock, and because of that, there will be reduced venous return, and because of that, there will be a reduction in cardiac output. So, in this figure, we can see, in the pictorial representation, we can see that there is a pneumothorax on the right side, and it is shifting the mediastinum to the left. And in the X-ray, shown on the right side, we can see there is a left side pneumothorax and it is shifting the mediastinum to the right. So, in these patients might present with chest pain or air hunger, they might be tachypneic, there will be respiratory distress, tachycardia will be there, and in tension pneumothorax, as I told, patient might be in hypotension. There can be tracheal deviation, trachea might be shifted away from the side of injury. There can be unilateral absence of breath sounds, there can be distended neck veins, and cyanosis is a last manifestation. So, always trauma is not the cause for pneumothorax. It can be either because of trauma or because of positive pressure ventilation which is given to a COPD patient or a patient with bulla because of bulla's rupture, or it can be some penetrating or blunt trauma to the chest, or it can be iatrogenic. By placing a subclavian or an internal jugular venous catheterization, we can accidentally puncture the lung and cause a pneumothorax. And it can be rarely because of a thoracic spine fracture. And suppose if the patient is having an open pneumothorax and instead of giving an occlusive dressing in 3 sides, if we give an occlusive dressing in 4 sides, it can also cause a tension pneumothorax. And the signs are, there will be, when we inspect the patient might be having reduced chest movements on the affected side, and air entry will be reduced on that side, and on percussion we will get a hyperresonant node, and trachea will be deviated to the opposite side with distended veins, and patient might be in hypoxia. And when we do an EFAS for this patient, we will be seeing the classical barcode sign or the stratosphere sign. If there is normal lung sliding, we are expecting a seashore sign, but in case of pneumothorax, we will see a barcode sign or a stratosphere sign. So, this patient, since this patient is in tension, we should immediately decompress that one. So, immediately we should let out the air out. So, we should place a large bore cannula or a large bore needle to the 5th intercostal space anterior to the mid-axillary line at a depth of 5 to 8 cm in adult. If that is not possible, at least we should make an opening with a finger thoracostomy. So, either a needle decompression or a finger decompression should be done, and that is just to let out the pressure to go out and just to let out the tension. Then after that, the definitive management is to place an ICD. Now we will talk about the open pneumothorax. So, open pneumothorax is same as the pneumothorax itself, but the defect which is causing that air leak is open out. So, it is not the defect because of an injury into the lung parenchyma as such, but it is because of an open wound, an external wound is communicating with the thoracic cavity. So, what is happening is that opening will act as a sucking wound, and this air will start entering through that wound because air usually goes to a path of least resistance. So, while this pleural cavity is having a negative intrathoracic pressure, the air will get sucked inside, and this air will not be able to go out. So, that will lead to a pneumothorax. So, patient might present with pain, breathing difficulty, tachypnea, reduced breath sounds on the affected side, and in a quiet ear, we will be even able to hear a noisy movement of air through that chest wall injury. So, as we see in this figure, air is entering inside the pleural cavity and it is not able to escape. So, the treatment is, we should place a plastic cover or an aluminum foil in a square shape that can cover the wound from 3 sides. So, we should keep it over the wound and we should tape the 3 sides, and we should not tape the 4th side. That 4th side should be left open. Okay, so the advantage of that is, whenever this patient is trying to inspire, the air will not enter inside the pleural cavity. That plastic wrap or the aluminum foil will cover that defect, and when the patient breathes out, the air can easily escape through that 4th area. That means the area which we have kept open. So, it will act as a valve-like, a flutter valve-like mechanism. Okay, suppose if we accidentally tape the fourth edge also, then air will again accumulate in the thoracic cavity and that will cause a tension pneumothorax. And the definitive management is to place an ICD on that wound, and we should place an ICD, but make sure that we are not involving that wound, because that need to be surgically repaired. So ICD should be placed remote from that wound. And definitive management for this open pneumothorax is a surgical closure of the defect. And next is life-threatening chest injuries in the circulation, that is the massive hemothorax first. So, massive hemothorax means a hemothorax blood accumulating in the pleural cavity more than 1.5 ml blood. So, that can be because of injury to any hilar vessels or any systemic vessels. So, what is happening is when we are examining the patient, we might get that the patient's air entry or the chest wall movements will be reduced on the affected side, and the patient's air entry will be reduced, and the patient will be complaining of chest pain, or patient might go into hypovolemic shock and all. So when we examine, we can also observe that the patient's neck veins might be flat because of hypovolemia, since patient is bleeding into the pleural cavity, or sometimes it can be even distended also because of the tension. The chest wall will be pushed to the opposite side. So, we can see distended neck veins also. And if there is any associated tension pneumothorax also, we will be seeing distended neck veins. And rarely, because of the mediastinal shift, as we told, there can be distended neck veins. So, first what is happening is, there will be a acute hypovolemia to the patient. So because of that, there will be insufficient preload of the LV, and the cardiac output will be reduced. And second, because of the collapsed lung, since the bleed is pushing onto the lung, there will be a collapsed lung that will cause hypoxia and ventilation perfusion mismatch. And the signs are absent breath sounds and dullness on percussion on the affected side. So thus we can confirm that this patient is having a hemothorax, not a pneumothorax. And when we are doing a fast, we can see the fluid getting accumulated. So in this image, we can see that the black area is the blood, and that is getting accumulated, and the Y-shaped area, this one is the collapsed lung markings. So this is classically seen in hemothorax. So management of this is, first we have to restore the circulation. So for that, place 2 large bore IV cannulas, infuse with crystalloids, and after infusing with crystalloids, then we will start blood transfusion. And to clear out that blood which is collected in the pleural cavity, we have to place an ICD. So that when we place an ICD, that will improve the patient's circulation. That will reduce the blood collected in the pleural cavity. Thereby, the lungs can expand, and thereby the circulation will get improved, and even the venous return to the heart will get improved, and the cardiac output also will be improving. So, place an ICD. So, single tube is inserted into the 5th intercostal space anterior to the mid-axillary line, and thereby we can restore the volume and we can decompress the chest wall. And we can plan on auto transfusion. That means we can plan on transfusing the same blood which is collected from the pleural cavity to the patient if we have the suitable device for that. And if at all we are finding that this patient is having more than 1.5 ml of blood in the thoracic cavity, that is an indication for urgent thoracotomy. And other indication for urgent thoracotomy is, if at all we are not getting 1.5 liter fluid in the at one stretch, if we are seeing that the patient is bleeding more than 200 ml per hour for at least 2 to 4 hours, that also may warrant a thoracotomy. And if this patient needs lot of blood transfusion, that is also an indication for thoracotomy, and to find the bleeder which is bleeding into the pleural cavity. So, if at all we are seeing a patient who is having a chest wound medial to the nipple line anteriorly and medial to the both scapulas posteriorly, that should alert a potential danger for a great vessel or a hilar structure, or even injury to the heart. And this patients are at high risk of potential cardiac tamponade and even massive hemothorax. So, and another important thing is thoracotomy should be done by a surgeon and it is not done by ED physician. So, inform a cardiothoracic surgeon and plan on a thoracotomy. So, these are the difference in physical signs in case of tension pneumothorax and massive pneumothorax. So, sorry, tension pneumothorax and massive pneumothorax. So, the breath sounds will be reduced in the affected side in both the condition, and during percussion we will be getting a dull note in pneumothorax and hyperresonant in pneumothorax, and the tracheal position, trachea will be deviated away from the affected side in both the conditions, and the neck veins will be distended in case of pneumothorax, and it will be collapsed in case of massive pneumothorax. It will be distended only if the mediastinum is pushed, and the chest wall movements will be reduced in both the conditions. Next is a dreaded problem, that is the cardiac tamponade. So, cardiac tamponade is the compression of the heart because of fluid accumulation in the pericardial sac, not the pleural sac, pericardial sac. So, because of this, what is happening is the patient will not be able to, the patient's heart will not be able to accept the venous return. So, thereby the cardiac output will get affected. So, it is most commonly seen in some penetrating or blood injuries that is affecting the heart or great vessels. So, this patient might come with a classical triad that is called as a Beck's triad, that is muffled heart sounds, hypertension and distended neck veins. And we can also find that there is a pulses paradox. Usually, there will be a fall in systolic blood pressure, but that will be less than 10 millimeters of mercury. And if there is a fall in systolic blood pressure more than 10 millimeters of mercury during inspiration, that is called as pulses paradox. And most common differential diagnosis of cardiac tamponade is tension pneumothorax of the same side, that of the left side. And we will be able to find this cardiac tamponade by doing a EFAST. So, in the EFAST picture, as we see in the right side, we can see there is a heart, and above that we can see a dark area, that is a fluid accumulated around the heart. So, these patients, the ideal treatment is emergent sternotomy and thoracotomy, and we should find where the lesion, where the bleeding is. We should find the bleeder and we should ideally repair that. But if at all this we don't have a surgeon nearby, then we should administer IV fluids. Then by administering IV fluids, we can increase the venous return and thereby improve the cardiac output transiently. And if the surgeon is not available, then we have to do a pericardiocentesis. It can be therapeutic, but it is not a definitive management. So usually we will be doing the pericardiocentesis by a subxiphoid approach. It is a temporary measure, and we will be placing a large bore needle through Seldinger technique to the pericardial sac, and we will be taking out the blood from the pericardial cavity. Thereby we can restore the circulation. So this ideally should be done under ultrasound guidance if we have the ultrasound machine. Next common complication in circulation is the traumatic cardiac arrest. So in trauma, patients might present with cardiac arrest. It can either be a pulseless electrical activity, ventricular fibrillation, or even patient might come with asystole. So the cause can be because of hypoxia or a tension pneumothorax or a profound hypovolemia, cardiac tamponade, any cardiac herniation, or even myocardial contusion. So this will require a thoracotomy, but the patient survival rate, even though we do a resuscitative thoracotomy, only 10% might survive. So in cardiac arrest, what we should do is start CPR. Then we should go for the ABCD management. So CPR should be done, high quality CPR should be done. Then we should give injection adrenaline as per the ACLS protocol. And if at all this patient is in VT or pulseless VT or VF, then we will have to administer shock. So the management is same only, and if at all this patient's airway is obstructed, then plan for a definitive airway and mechanical ventilation. Do an EFAST simultaneously and find what is the cause of cardiac arrest, and if we are getting the cause as any cardiac tamponade, any pneumothorax or something, then we should do the necessary measures like placing a ICD, or by needle decompression or pericardiocentesis should be done. So that is a management of the cardiac arrest. We should manage the cardiac arrest. Along with that, we should find what is the cause of cardiac arrest, and we will have to manage that. And if at all we are finding a surgical cause in the thoracic cavity, we should call the surgery team and plan for immediate resuscitative thoracotomy. Next, so these were the life-threatening chest complications. Now we will be talking about some of the other complications or the other injuries which can happen in the chest. These are not life-threatening, but these should be identified in the secondary survey. So one is a flail chest. Flail segment of the, means that means any part of the thoracic cage is moving opposite to that of the normal chest wall movements. So it can either be because of multiple rib fractures, 2 or more adjacent rib fractures, rib fracture might be there, or it might be because of a single rib that has been separated from a costochondral junction. So we can see that that segment is moving in an opposite direction to that of the chest wall. So, and in the X-ray we will be able to see multiple rib fractures. And another condition is pulmonary contusion. Pulmonary contusion is just that the lung is getting bruised because of the trauma. And in children and all, we will be seeing pulmonary contusion even without any flail segment or any rib fractures. So in this image, we are able to see some segments. Flail segment is there. That means 2 or 3 adjacent ribs are getting fractured at different sites, and that segment is moving separately. And this is the CT and X-ray image of lung contusion. We can see on the right side there are contusion or whitish areas are there. This is because of contusion or opacification of the lung. So the treatment for this is give adequate oxygen to the patient. If the patient's oxygenation or ventilation is getting affected, and if the patient's hypoxia is increasing, and if the PaO2 is less than 60, patients might require intubation and mechanical ventilation. Give cautious fluid resuscitation. We should avoid patient going into pulmonary edema. Give adequate analgesia, either IV analgesia, or we can give any local anesthetic, or we can give intercostal nerve block. We should ideally avoid narcotics because that might cause respiratory depression. And if there is some flail segment, we can ideally strap that flail segment so that it will not move in a paradoxical way. Next is a traumatic aortic disruption. It is a common cause of sudden death, and the patients who is having aortic disruption will survive only if the disruption is incomplete. If there is some incomplete laceration, only patient might survive. Otherwise, patient might die on site. So there can be a widening of mediastinum. There can be obliteration of aortic knob in the X-ray. The trachea might be deviated to the right side. In the X-ray, we might see obliteration of the space between pulmonary artery and aorta, and there even can be deviation of the esophagus, so that we will see the nasogastric tube deviated to the right side. There can be associated left side hemothorax, and fracture of the first 2 ribs and scapula might be associated with that. So we can diagnose it only with a CT scan. That is an accurate investigation of choice, and there is high mortality for this condition. So if at all the patient comes with incomplete laceration, the patient might complain of chest discomfort, hypotension. There can be dysarrhythmias which can be seen. There can be some premature ventricular contractions. Then there can be unexplained sinus tachycardia. AF might be there. Some bundle branch blocks might be seen, or even ST segment elevation can also be seen. So this patient should be monitored for 24 hours, and the ideal treatment is surgical repair. And we should make sure that in the ER, we should make sure that we should avoid tachycardia and avoid patient going into a high blood pressure because it can worsen the bleed. So make sure that heart rate is targeted less than 80 and the blood pressure should be controlled to goal a mean arterial pressure of 60 to 70 millimeters of mercury by either using esmolol or any calcium channel blockers like nicardipine. We can use nitroglycerin or nitroprusside. We should give adequate pain control and immediately involve the surgery team for an open repair. Endovascular repair should be done. Now next is a traumatic diaphragmatic injury. It is mostly seen in the left side because the right side is protected by the liver. So the left diaphragm is not so safe. So left diaphragmatic injury is mostly seen and it is frequently missed. So it might only be diagnosed if that part of the stomach or the intestine which is getting inside the thoracic cavity becomes tossed or strangulated. And in X-ray, it is early picked up if at all we are seeing a elevated diaphragm or a gastric tube which is in the thoracic cavity. In such condition only we will be seeing that. So in these conditions, we should insert a gastric tube. Then we should decompress the stomach of this patient. Then the treatment is a direct repair. Surgical repair is the treatment. So if this thing is, if there is a traumatic diaphragmatic injury, the contents in the peritoneum will be going into the thoracic cavity, and that will affect the oxygenation and ventilation of this patient. So surgical repair is warranted. So in the ER, the target is to decompress the stomach and make sure that nothing is pushing into the thoracic cavity. So this is the image of that. In the left side we can see the abdominal contents are herniating to the thoracic cavity, and the right side we can see the X-ray film of that. Next is a blunt esophageal rupture. So what is happening is there is leakage of the esophageal whatever things are going to the esophagus into the mediastinum. So there can be a crunching sound known as a Hammond sign over the heart, and patient might be having severe chest pain also. There can be associated hemothorax and pneumothorax. And in such conditions, the treatment is direct repair of the esophageal rupture. Then another complication or the injury because of the chest wall trauma is a systemic air embolism. It can be an acute complication of severe chest trauma, or because of any positive pressure ventilation, or because of the some air which is entering into the blood vessels, and patient might present with some symptoms like severe arrhythmias, CNF defects, confusion, or hemoptysis. And the treatment is make the patient lie down in a flat spine position, give adequate oxygen. This oxygen can decrease the air bubble size and it can displace the nitrogen and promote resorption of the embolus. Or we can give hyperbaric oxygen therapy. And the prevention is if it is because of a unilateral lung injury, we should isolate and ventilate the uninjured lung. And if this embolus is because of a lung injury as such, if we are diagnosing it like that way, we should resuscitate the patient, and we have to plan on immediate thoracotomy and to clamp the lung or the injured area which is involved. Now we will discuss about the procedures done in life-threatening chest trauma. One is a needle thoracostomy, which is usually done in tension pneumothorax as an initial step. So select a needle, 14 to 16 gauge needle in adult and 20 to 22 gauge needle in children and neonates. And the site of insertion is the 5th intercostal space in the mid-axillary line, or 2nd intercostal space in mid-clavicular line, which was usually recommended for children, but in adult and children now we are preferring the 5th intercostal space itself. And so select a needle, attach a 5 or 10 ml syringe with some saline in that, and insert it into the space. Then we should check for the bubbling. If at all we are finding the bubbles, that means that we are inside the pleural cavity, and then we should open the we should remove the syringe so that the air will get opened and air will go outside, so that we can decompress the thoracic cavity. And then we can connect it to an IV set with a bottle with sterile water below the insertion site, so that the air in the bottle will not enter inside the pleural space. So that should be kept below the insertion site. So this is the image. So if we are inserting the needle, first insert the needle, then we should withdraw the needle so that the catheter only will be in place. And when the lung expands, we will not the lung will not unnecessarily prick into the needle. So after inserting the needle and catheter, remove the needle so that only the catheter will be in the place. Now we will talk about the tube thoracostomy. So in order to place an ICD or a tube thoracostomy, we should have 1 to 2% of lidocaine. We should have adequate needles and syringes. We should also keep scalpels number 11 and number 10 blades. We should also have clamps, at least 3 clamps should be there. We should have straight scissors, chest tube should be there, then silk to secure the tube in place. We should also have needle holder. We should have gauzes, then drain sponges, then elastic tape, and we should have adequate protective measures like gown, gloves, drapes and all should be there. And we should wear mask, protective eyewears and all, and povidone iodine or chlorhexidine to make the area sterile, and the drainage system. So the steps are, first we should have sterile precautions, wear gloves, gown, mask, eye protection and hair cover. Then when we are selecting the tube, if it is an adult patient and if this patient is having pneumothorax, we will be selecting 18 to 14 French ICD. And if at all if this patient is having hemothorax, we will be selecting a wide bore trocar, that is 24 to 32 size trocar will be selected because if it is hemothorax, there might be some clots, and also in order to, if it is we are using a small one, the clots might obstruct the ICD, so we want a larger size in that. And we should give adequate analgesia and some sedation to the patient. Then we should make the area sterile by using chlorhexidine. Then we will be ideally inserting the tube either to 4th or 5th intercostal space in the anterior axillary line or in the mid axillary line. Then we should give adequate local anesthesia. 1 to 2% lidocaine can be used. The required amount is 4 to 5 milligram per kg if it is with epinephrine, and 5 to 7 milligram per kg if it is without epinephrine. And then we will make a small incision just above the lower rib, 2 to 3 centimeter length incision. Bluntly dissect by opening and closing a clamp and create a short subcutaneous tunnel till we reach the parietal pleura. So from the incision side, we will be tunneling inside and we will be targeting cephaloid. We will be inserting the clamp or the artery forceps just above the lower rib, and we will be moving cephaloid towards the intercostal space. And if at all we feel that there is a sudden decrease in pressure, that means the pleura is punctured. And once we are inside the pleura, not penetrate further in, we should safeguard that tunnel made by us by inserting the index finger. And then we should insert the ICD tube or the trocar, making sure that the sharp edge of the trocar is withdrawn inside and it should not expose out, or it should not injure the thoracic cavity. So the trocar should be pulled back, and then we should insert the ICD or the ICD into the pleural cavity. And then if we are seeing the air or the blood coming out, that means we are in the pleural cavity itself. Then we should connect it to the ICD tubings and to the underwater seal, and we should check check for the adequate lung expansion with the chest X-ray. So this is the figure. In figure A, we will be seeing that we are making an incision. Then in the figure B, we will be using a artery forceps. We will be dissecting just above the lower rib. We will be dissecting inside till we reach the pleural cavity, the parietal pleura. Then after reaching the parietal pleura, we will be puncturing the parietal pleura, and we will be making a small opening in that, and we will then insert our index finger into that, and using the index finger as a guide, we will insert the chest tube to the cavity. Then after that, then we will be suturing the ICD in place. So this is the figure. I hope you understood. Then once the tube is in position, then we will have to suture that with silk. So from all the fourth side around the chest tube, we will have to take incision bites from the skin, and we should then suture it onto the tube. Next, we will move on to the procedure, that is the emergency pericardiocentesis, which is done in cardiac tamponade. So in this, patient is ideally positioned in 30 to 45 degrees, or if the patient is in distress or the patient is in cardiac arrest, if there is ongoing CPR, this can be done in supine position also. So it is a painful procedure. So ideally sedate the patient. Usual approach is subcostal approach, and other approaches like parasternal approach or apical approach can be used. Each has its own advantages and disadvantages. So if we are going through a subcostal approach, there is high risk for the right ventricle to be injured, because right ventricle is not as thick as the left ventricle. So there is high risk for the right ventricle to be injured, and thereby we will be penetrating into the heart. If we are going through the parasternal axis usually is within 3 to 5 centimeters from the sternum. If we are going through that way, there is high risk that there is an internal mammary artery might get injured. And if we are going through the apical approach, that is through the apex, there is high risk for the left ventricle to be injured, and we might penetrate into the heart. So usually the subcostal approach will be preferred, and for doing this, we should arrange certain things. So equipments for this procedure is sterile gloves, gown, mask, sterile barrier drapes, chlorhexidine, then 20 to 25 gauge needle to give local anesthesia, then syringes from 10 and 60 size syringes should be there, 3-way stopcocks should be there, plastic drainage tube should be there, 18 gauge needle, that is the introducer needle into the pericardial sac. Then we need a guide wire, then 6 to 8 French drainage catheter, or a pigtail or a sheath, or a central venous catheter, so that we can keep the sheath in the pericardial space and we can continuously aspirate the pericardial fluid. And we should also have an ultrasound. If at all we have an ultrasound machine, we should need an ultrasound machine also. So I will explain the steps. First, we should drape that area, sterile, that area should be made sterile. Then we should slowly advance the pericardiocentesis needle with continuous aspiration. So here I am going to tell about how to approach it through the subcostal view. So insert it 1 centimeter below the sternum, that means the CF sternum. Then we should target to the left shoulder and we should advance it. While doing that, we should continuously aspirate, and if we are seeing blood coming through that, that means we are inside the pericardial sac. Then we might feel a bit resistance just before puncturing into the pericardium, and sometimes patient might feel a very sharp acute pain once we enter inside the pericardium. So once we are in the pericardium, we will see that the blood start coming from that. So we should stop advancing the needle further and we should aspirate the blood. Before that, we should make sure we should stabilize the needle, make sure that the needle is not coming out or going further in. So while we are draining the pericardial fluid, we should connect it to a 3-way. We should aspirate, and then we should, using the 3-way, we should remove the pericardial fluid. Do not withdraw large amount of pericardial fluid, because that can cause pulmonary edema. So the body might not be adopted with the reduced venous return, but still this, if at all the venous return increased because the pericardial tamponade effect has reduced, the venous return will increase. So that will cause a transient pulmonary edema to the patient. So we should not remove so much of fluid. Then after that, we should once we have removed some fluid through Seldinger technique, we have to insert the guide wire, and then we'll have to insert the sheath, and then we can plan on aspirating the pericardial fluid further on a later basis. So this is all about the life-threatening chest wall injuries. I hope you've understood that. Thank you.